Hello and welcome. Today we're delving into the intricacies of a rare but serious genetic disorder that significantly impacts the urinary system, primary hyperoxaluria. Primary hyperoxaluria, or PH, isn't caused by infection or injury. It's an inherited genetic condition. That means it's passed down from parents to their children through faulty genes. Specifically, PH arises from mutations in genes that are responsible for producing certain enzymes. These enzymes are crucial for breaking down glyoxylate, a naturally occurring substance in the body. When these enzymes are deficient or absent due to the genetic mutations, glyoxylate gets converted into oxalate, leading to its overproduction. Now, let's talk about the pathophysiology, or how this disease actually works in the body. The key problem in primary hyperoxaluria is the excessive production of oxalate. This excess oxalate then enters the bloodstream and is filtered by the kidneys. Because oxalate isn't very soluble in water, especially when calcium is present, it tends to bind with calcium and form calcium oxalate crystals. These crystals can deposit in the kidneys, leading to kidney stones. Over time, these deposits can damage the kidneys, causing a condition known as nephrocalcinosis. More critically, if the kidneys fail due to this ongoing damage, oxalate continues to build up in the blood, circulating to other organs and causing systemic oxalosis. This systemic oxalosis can affect the heart, bones, eyes, and other tissues, leading to significant complications. Primary hyperoxaluria is a rare disorder. While the exact prevalence varies based on geographic region, it's estimated to affect approximately 1 to 3 individuals per million in developed countries. Consanguinity, or marriage between close relatives, can increase the risk of inheriting the affected genes, making the disease more common in certain populations. The signs and symptoms of primary hyperoxaluria can vary depending on the age of onset and the severity of the condition. In infants and young children, it can present with failure to thrive, recurrent kidney stones, and early kidney failure. Older children and adults may experience recurrent urinary tract infections, blood in the urine, pain in the flanks or abdomen associated with kidney stones, and progressive kidney damage. In advanced stages, symptoms related to systemic oxalosis might appear, such as bone pain, heart problems, and eye problems. Diagnosing primary hyperoxaluria involves a combination of clinical evaluation and laboratory tests. A urine test can reveal elevated oxalate levels. Blood tests can assess kidney function and measure oxalate levels in the blood. Genetic testing can identify the specific gene mutation causing the condition, confirming the diagnosis. In some cases, a kidney biopsy might be necessary to examine the extent of oxalate crystal deposition in the kidneys. While there are 3 known types of primary hyperoxaluria, type 1, type 2, and type 3, they all share the common feature of oxalate overproduction. Type 1 is the most common and typically the most severe form, resulting from mutations in the AGXT gene. Type 2 is caused by mutations in the GR gene and is generally less severe than type 1. Type 3 is caused by mutations in the HALGA1 gene and may have a variable presentation. The treatment of primary hyperoxaluria focuses on reducing oxalate production and preventing crystal formation. High fluid intake is crucial to dilute the urine and reduce the concentration of oxalate. Medications, such as pyridoxine of vitamin B6, for some patients with type 1 PH, can help reduce oxalate production. Potassium citrate can help increase urine pH and prevent calcium oxalate crystallization. In advanced cases, when kidney function is severely compromised, dialysis may be necessary to remove oxalate from the blood. Ultimately, a combined liver and kidney transplant is often the definitive treatment, especially for type 1, as it replaces the defective liver enzyme and provides a functioning kidney. Currently, there are no definitive ways to prevent primary hyperoxaluria since it is a genetic disorder. Genetic counseling is crucial for families with a history of the condition. Carrier testing can identify individuals who carry the mutated gene, and prenatal testing can be performed during pregnancy to determine if the fetus is affected. The prognosis for individuals with primary hyperoxaluria depends on the severity of the disease, the age of onset, and the effectiveness of treatment. Early diagnosis and aggressive management can significantly improve the outcome. Without treatment, the disease can lead to kidney failure, systemic oxalosis, and ultimately death. Recent advances in treatment, including combined liver and kidney transplantation and the development of novel therapies like RNA interference aimed at reducing oxalate production, are showing promise in improving the long-term outlook for patients with this challenging condition. Research continues to explore new and more effective ways to manage this disease and improve the quality of life for those affected.